Most experience in ITP. He's got one of the biggest registries in the world that he's in charge of, and I think that we can learn a lot from Drew.
Oh, thank you. Okay. Well, I'm on the thin ice today because AI is, I don't fully understand. I think it's very complex, but I think the take home from this talk is that we are getting nowhere with the technologies we have. Like nowhere. In 70 years, nothing's changed in diagnosis or personalization. So we need some tool, and I think I'm hoping this will be the tool. Okay, these are my disclosures. And I was thinking, like, if you have a patient with low platelets, how do you know it's ITP? You don't. So how do you decide if a patient's low risk or high risk? How do you stratify them? You can't. Can you? You can't. And if someone needs treatment, how do you know for that patient what the best treatment would be for that individual? Given all the new drugs that are coming through, which is fantastic, how do you know which is the drug for them? You don't. Do you? You don't. So this is where we are today. Loads of therapies and no personalization. So we do need, for this syndrome, we need some way of diagnosing it, if it exists, primary immune thrombocytopenia. What the syndrome is, we cannot diagnose this, so we don't know what we're treating. We cannot stratify anyone. Occasionally, if you know a patient, you can say this person is high risk because I know how they behave. But up front, the new patient, you don't know who's going to bleed or not bleed. And this will help us avoid overtreatment if we can stratify them into high risk, low risk, intermediate risk groups. And then the treatment choice. We have a big choice of therapies for ITP, but there is zero personalization. Everyone gets the same. And you wouldn't get that for cardiac disease, for orthopedics, for oncology. You'd never get the same treatment. It's personalized. And I think if we don't use AI, what else have we got? How else are we going to advance this? I don't think we can. So I think the AI and machine learning, these are great tools, and they're developing so rapidly. It's changed everything, the way we work. We all use AI now, don't we? We all use ChatGPT. There's Mulder's, Grok, ChatGPT, Gemini. There's so many other AI tools for research, for illustration, for PowerPoint, for analysis of documents, for everything, drawing up legal contracts, everything. It's amazing. And they can analyze huge amounts of data really quickly, much faster than we can. And AI's made big inroads in many, many diseases in medicine, not ITP yet, but in many diseases. And I think it will help with our issues that we have. But it needs big data. And that's something we do have, and it needs obviously big computers. And we have loads of data. But I want to focus on one, which is our strength in ITP, is the registries. We have registries. We collect data longitudinally, clinical data, laboratory data, research data over 25 years. I was thinking, if you take together the UK adult registry, and we also have the secondary ITP registry and pediatrics bundled into one database, which we're running from the Royal London, the French registry, Guillaume and his registry and all their data, ISIS, the Intercontinental Group, they've been doing it for longer than we have. Must go back about 30 years, probably, Paul Imbach and Thomas Kuhne. They've got tons of data, mainly pediatric. And there are other registries. So we've got all this data sitting there waiting to be used for something. And we're tinkering with little bits of data, but now we've got AI, we should be using it. And we know that it's made big advances in things like radiology, imaging, pathology, imaging, cytology, slides, biopsies, endoscopy, imaging, ultrasound imaging, MRI scans, CT scans, biochemistry, anything with lots of numbers that it can read has made big inroads there. And for other diseases, not for us, not for ITP, it has helped with predicting what will happen, disease prediction, treatment recommendations. Wouldn't that be nice in ITP if we could get treatment recommendations based on an AI machine learning model? Patient monitoring, genetic analysis, it goes on and on and on. There's tons that it can do. And we've already seen some papers appear. These are the malignant hematology, hemato-oncology, CML, CLL. We've got Philadelphia negative myeloproliferative diseases, largely from one group publishing these. Mohammed Yassin, I think, from Doha, is publishing more than anyone. Non-malignant, we've got thalassemia, using AI and machine learning to diagnose thalassemia. Sickle, iron deficiency, and then this one paper from a couple of years ago on thrombocytopenia, not ITP, multiple types of thrombocytopenia, again from Mohammed Yassin's group. And this is their paper. It's one of the first ones that I read. And these are, I find, do you read papers on AIs? Do you find these hard to read? I find them really heavy going. I don't, someone's nodding. It's not easy, is it? I think there's something missing in my head that just doesn't let me understand this. It's so complex. But hopefully it will get easier. It's very easy. So all questions for my talk will be directed to this man here. It's like, yeah. Well, you have published in this. You have published in this area, so you're an expert. Okay, ITP. So looking back, a couple of years ago, there was hardly anything published. I think there's actually 3 papers if you put in ITP and artificial intelligence or machine learning. There was one on a bleeding prediction model, which is great. It'd be lovely to know who might bleed. That's a big clinical sort of thing that we want to avoid. We don't want people to bleed. And then there's one here on drug-induced thrombocytopenia, trying to differentiate from other types of thrombocytopenia. By 2024, we had 8 papers published. And then this year, 9 papers published. So there's still small numbers of papers for our specialty, which is a little bit depressing, considering we're sitting on a minefield a gold mine of data, not minefield, a gold mine. And if you look at these, I can't see very well from me. This is way back in 2005. In medicine, the whole of medicine, a couple of hundred papers, and then it goes up and up and up. And then if you look, by 2023, 23,000 papers using AI in medicine. Of course, in 2010 to 23, we had 8. But look at radiology, pathology, radiology, psychiatry, oncology, neurology, all the specialties. But we don't appear anywhere here. And we have so much data. We probably got more data than they have. What do they have in psychiatry? What kind of database? What do they use? What are they doing machine learning on for psychiatric disorders? Just a couple to mention here. Then I'm going to run through a few just to show you the proof of concept. So this is one, I might touch on this one, the cytokines one. And then we published this thing, which is supposed to, it's like, could it assist us in the diagnosis of ITP? And I'll give you a spoiler, it doesn't really help us, actually, it didn't. But it was proof of concept, it was worth doing, but it hasn't helped us crack diagnostically this disease. And then there's Waleed's paper with Nikki looking at could machine learning revolutionize how we treat, and it not only revolutionize how we treat, how we diagnose and manage, not just the treatment of ITP. So I'm going to run through a couple here. There's the diagnostic paper, one diagnostic paper that's appeared. There's a bleeding paper, bleeding risk in pediatrics. There's this one on chronicity in kids. And then there's a treatment response AI machine learning paper. And then there's another treatment response one in pediatrics and one in adult. And you'll notice a certain theme coming through the papers here in terms of the groups publishing. Surprise, surprise, it's from China. Not much from anywhere else yet. I mean, they're miles ahead. They're miles ahead therapeutically. They're miles ahead in AI. So I'm just going to run through some of these. I cannot really explain fully the algorithms because I don't understand them. But this is one looking at using chemokines to see if they could diagnose ITP and also assess bleeding. So they wanted to differentiate primary ITP from other types of low platelet disorders. That's one. And then could they predict the bleeding risk? So they had a discovery cohort, they had a validation cohort. Median age is quite low, 37, that's quite low for ITP. You'll know, John, and you'll know Luminex, I don't know what Luminex assay is, but anyway, these Luminex assays. And the algorithms used were random forest, which is used a lot in these papers. This thing called support vector machine, recursive feature elimination. They're really easy to remember, these terms that they come up with. And then they did rock analysis. Yeah, I know. Oh, sorry, do you want that picture? I'll go back. There you go. You get it? Do you get it? Okay. So anyway, so in terms of diagnosis, in terms of chemokines, this was elevated CCL20, then these were lower. That was diagnostically. And then for terms of bleeding, these ones were raised. Again, I don't really know what these are. These are just chemokines. I'm sure John and Rick will know what these are better than us. And their conclusion was that these distinct signatures within these patients helps you to diagnose primary ITP, they say. I mean, I'm not sure. And also predict bleeding risk. Well, I mean, that's great if it does. But they're going to validate it with obviously a much larger study. But it's interesting, if nothing else. Right, here's another one. This is one to predict rituximab responses in children with primary immune thrombocytopenia, trying to go towards a more personalized care model, which is exactly what we were aiming for. We need personalized care We don't want to treat everyone the same. So they wanted to develop it and then validate it to predict which kids would respond to rituximab and which would not. And they had over 150 kids, age 1 to 16, primary ITP with low-dose rituximab, Beijing. The outcomes were complete response and partial response. They chose 73 variables, an awful lot of variables. There were clinical variables, immunological variables, treatment history, and they found 25 key predictors, and they used these models, logistic regression, blah, you can see here random forest, this thing called XGBoost, whatever that is, and then this multi-layer perceptron, which comes up a lot. And the top features were, in terms of positive, i.e. predictive, ANA theta, thyroglobulin antibody, corticosteroid response, and the bleeding severity. These were positive predictors, and then negative predictors were thyroid peroxidase, CD3 positive, CD4 positive, IL-17 positive T cells, and then the disease duration. The multi-layer perceptron performed the best of all the algorithms that they used, and they used these things called SHAP plots, which again I've never heard of. If you have a high ANA theta, you get a better response. If you have a longer disease duration, you get a worse response. And then there's this, which I really don't want to go through because I don't understand it. It's just basically the data, and they sort of streamline it, then they use their 4 algorithms, and then out comes the answer at the end. So they say it's a good model using 25 readily available, and they are readily available variables that we can measure, and it reliably predicted initial response to Ritux, which is nice, avoids kids having it who wouldn't respond, maybe. And if it's externally validated, this is the key, it has to be validated with bigger studies, and they're planning a multi-center study from that. So maybe that'll be personalizer for kids. This one here, these guys developed, this is from last year, a model to look at who would develop chronic ITP. I don't understand what the driving need is to work out who's going to be chronic in a way, because you're going to find out in time anyway, aren't you?
It's for treatment. If you know that patient's going to become chronic, if you treat them earlier, it's a better prognosis.
Is it?
That's what they say. Yeah.
Do they say that? I don't know. Well, I'm not sure that's true, but anyway, they wanted to see if they could work out who's going to become chronic. At initial diagnosis, so right up front, who's going to become chronic, using demographic, i.e. basic clinical data that we all collect, and immunological data, over 660 kids, age 1 to 16, newly diagnosed primary ITP, again, Beijing, treatment naive, followed for 12 months or longer. And, oops, let me go back one. They used 4 algorithms, the same ones again, logistic regression, random forest, the SVM, the whatever that is, XGBoost. And they had 16 predictors, 14 of them were immune and 2 were demographic, including T cell subsets, surprise, surprise, Th1, 2, 17, Tregs, the Th17 to Treg ratio, gamma delta T cells, double negative, etc., plus age plus sex. They had a training set and a test set, and the accuracy is high. And then they did this again like the other group. I hate these diagrams. They get your patients, you weed them out, and then you do this and put them through algorithms, and you get a curve, and then you publish it and get a lovely paper. The key predictors were age, Th17, the Th17 to Treg ratio. These are not surprising, really. Th1, pro-inflammatory, double negative T cells, high risk profile. A child over 11 who's with Th17, plus, where was it? Yeah, Th17 more than 0.55, TCR gamma delta positive T cells more than 20 give you an 85% high risk profile. And low risk would be if you were aged under 6 with a low level of Th17, again, so anti-inflammatory, give you major low risk, so there's nothing majorly surprising in that, but they conclude that using these routine markers could predict, for instance, a diagnosis, which may be useful, and the age and the Th17 to Treg imbalance were the dominant risk factors there. But then again, it needs validation, it needs standardization and a bigger study. Sorry, I'm nearly through this, I know it's hard work, but nearly through it. I know, I hope so. And I want a good review on Trustpilot, by the way. This is another bleeding risk. Again, at least they're going for things that are clinically useful, like who's going to bleed, what treatment would work, and maybe who's going to become chronic. So they want to look at moderate to severe bleeding in pediatric and kids again. I don't need to run through all this. It's China again. It's 286 children. They excluded the secondary ITPs. They found 13 predictors here, and they used 7 algorithms. Why do you have to use 7 algorithms? I do not know, but anyway, they used 7 algorithms, and they had a training set and a test set. And the best model was this XG boost here, and the top predictors of bleeding were older child, younger diagnosis, age, and a low initial platelet count, good calibration, blah, blah, blah. And there's their graph, which again looks pretty good. This is the XG boost. So they conclude that this forecast can predict bleeding, which is useful if it really does. And then you can work out your high risk. So we're getting towards stratification now, which is one of the goals. It's what you would do in AML or myeloma. You want to stratify into low risk, intermediate risk, and high risk. If we can stratify the children, then you avoid a lot of children having unnecessary treatment. Okay, this is probably the last one, I think. This is looking at various drugs and whether you're likely to respond. For any treatment, they say that, so it depends on the pathophysiology within the patient, it depends on their demographics, like how old they are and how long they've had ITP, and then their metabolic background, if you like. And they wanted to look at developing models that would predict a response to 3 drugs, 3 classes: glucocorticoids, TPOs, and rituximab. And through a very long, convoluted process, which I don't fully understand, for some reason for steroids, they chose XG boost. Why? I don't know. I don't understand it enough to know why they chose that. For the TPOs, they wanted this one, and for the rituximab, they chose this. Let me just speed up. This is very complex here, but I want to show you the last slide here, which you get a scoring system here based on the various therapeutics. So for steroids, if the score is 3 or more, then that predicts poor efficacy. For TPOs, if the score is 5 or more, then poor, based on these various parameters. And then for rituximab, if it's 3, then it's poor efficacy. And this is quite useful if it works. But I can't imagine us doing this at the London. It just looks really complicated. But maybe it will be a program. You can just punch a few numbers in, and then it will just say, they'll come out with a ticket saying high risk or low. I don't want to go through all these stages manually. It just looks really tedious. So, yeah, I think this is all very promising, and I think it's very exciting. There's a lot happening, and we have to embrace this, because, as I said, we're getting nowhere. We're not. I mean, if we don't use this, then in 10, 15 years we'll still be at the same stage, but by that point we'll have about 100 new drugs, and we still won't know where to use them, and which patient, at what stage. And we still can't diagnose it, but we're still going to be back in 1950s hematology, which is what we're at the moment. We really are, don't you think? If you look at the old 1950s papers and what we're doing now, the description is the same, the management is much the same, we've got fancy drugs, but beyond second line, we have no idea what to do. We need ethical standards. That's true for all of AI. We need some standardization, because it's going to end up we're all using different methodologies, and it's not going to work. We're going to have to standardize this so we can compare like with like. And we need to improve the knowledge for healthcare professionals. And I think one of the big barriers for AI is the fact that if you just try and read a paper, it is so, once you get past the initial couple of sentences, it's so complicated that it just puts you off, and I don't understand it. And we have to get patients used to this as well, and they probably are to an extent. But we'll have to, and so there's still a lot to do here. So I think it's moving very fast. We are behind a lot, well, most specialties, I think. The early studies, I know these are all a bit, I mean, they are very Chinese related, but nonetheless, at least they're going for it and doing something, which is more than we are at the moment. And it does show some value. I think it does look like it will help diagnosis to an extent. And maybe it will then help us subdivide ITP into what truly is primary and what these other underlying disorders are. And then you can put them to one side and not treat them like ITP. They say it outperforms traditional scores in their small cohorts. That's fine. They've achieved proof of concept, which is what they wanted. So standardization we need, validation we need. We need to share data. We need to use our registries, Guillaume. We need to pull the data. The more data we have, the more powerful it becomes. And then we have to decide what models, what kind of algorithms and models we're going to use for ITP. And then from all the data we have collectively, because you are, Guillaume, collecting data, we're trying to pool our resources, are we not, at the moment? And that would be a lot of information on ITP. So I think that's my biggest hope is that the registries will answer many of these questions. Without the registries, I don't think we can use really AI in a single center. You're not going to see enough patients. China does it because it's such a big country and they get a lot of ITP patients through the door. We don't. Every hospital, certainly in the UK, might have 100 ITP patients or 50, and that's it. And that's not enough. You need hundreds and thousands of patients. So on that, I'm gonna stop, and I'll take questions if they're easy. Okay, Dr. Semple, thank you.
Thanks, Drew. Really interesting talk. I guess the thing is a logistic issue, is that all of those things that you showed, like the cytokines, the chemokines, the T cell subsets, they take time to do. So you bleed the patient, you got to send it to the lab, and it takes a day at least to do some of those assays, maybe a couple of days. Yeah. I guess how long are you willing to wait for those results if you've got a patient?
I don't think you would wait. I think you start your initial therapy. We would treat them as we normally would in the old-fashioned way that we do and just give steroids or IVIG or whatever up front while we wait. We wouldn't just wait for this to come for a brand new patient where you don't know what's going to happen. If their platelet count is, say, less than 10,000, they're brand new, you're not going to sit and wait for some lab results to come. Right. Because then they may die in the meantime. You say, well, I was waiting for the chemokine results to come back. No, that wouldn't work. We just have to treat them as normal, and then when that comes, that may alter our management, depending on what comes back and out of the models.
I guess, right. But the thing is that for some of these predictive models, they'll say you either treat that patient or you don't treat that patient, and you go ahead and treat them, and it comes back, you shouldn't have treated them.
But this may be more useful for the non-newly diagnosed patient, because if we're talking about things like rituximab and stuff, that's not upfront, because by that time they will have had their first-line therapy, so you'll know them a bit. And then you're thinking of your next therapy. So there may be a way of saying, or I've given this patient a TPO or two and now they're failing or they can't tolerate it or it's contraindicated. Should I use a BTK inhibitor or fostamatinib or an anti-FcRn? So that would be quite nice if you could then have some, but there's no major rush for that usually. The only real rush is right up front when they're in the emergency room with platelets that are less than 10 and maybe bleeding. Then we can't wait, we just have to do something. Beyond that, it's usually more relaxed.
Yeah, so nice talk, interesting concept, but I'm just thinking, like, should we not be thinking more about what you put into the system? Because you have such heterogeneity in ITP patients, they have all on different underlying mechanisms. You put all of that together and hit them with AI, and then you get interactions that are not relevant. So what comes out, and you, yeah. So,
absolutely, throw everything at the wall and see what sticks. No, I agree completely. I think what should go in should be all the demographics. I wouldn't weed those out. So put all the demographic data in. But when it comes to laboratory type data, we have to, as a group, decide what we should be studying. Not like he's studying chemokines, he's studying cytokines, he's studying something else, because that doesn't make sense. We should agree if we were going to choose, say, 12 parameters in ITP as a group, what would those 12 be? And we all do the same 12, so we're comparing like with like. Because there are hundreds of things we could measure. And as you say, if you throw everything in, it's like the old Bonferroni correction where you do, SNPs and things, something's going to come out positive, but it means nothing. So we have to make it meaningful. So yeah, focused and, yeah, exactly, I agree, totally.
Yeah, yes, Drew. I mean, you talked about you mentioned the registries, and my experience. I mean, most of my experience with machine learning is from the thrombosis field, because there we have a single center, we have thousands of patients over the years, and we're doing a lot. And the Chinese are not so interested yet in thrombosis as in ITP, so that's good for us. So my experience is that if you have a set of like 10 or 20 variables, and whether you use classical statistics or you use machine learning, you get the same results. But what the advantage here in machine learning is not only registries, we have to work on biobanking and then do the multi-omics. And that's our hope. We can identify. Yes, it can help us. There are tools to tell, okay, these 10 cytokines or cells or whatever these are really something you can find.
No, I agree.
And then you apply all these algorithms, which is not the way we do classical statistics, we define everything a priori in statistics. I'm sitting there, so I have to be very, very correct. Well, but that's the
No,
right
no, I
way.
agree, I agree.
Here you do the opposite. You put everything in without a hypothesis and generate something.
We want to avoid that, because that wastes time, it wastes money, and, but because they're using like 7 algorithms for one study. We need to choose like 2 or 3 at random for us and something else, and just try and be focused. Start small and incremental, but...
I mean, I fully agree. That's the future. At least something new that we can use, and
there's
maybe
nothing else
we'll
coming
succeed,
along.
maybe not. But
there is nothing else coming. There's nothing. If not this, then what? There's
then
nothing.
what?
There is nothing. And I don't want to get to the stage, as I was saying, where in 10 years' time we've got about 20 new drugs sitting there, and we still don't know how to sequence them. That's really frustrating. It's very, very frustrating. Okay, right. Thank you.